Hello, everyone. Welcome to Webinar Wednesday, today on November 22nd, 2023. My name is Melissa Haddad, and I will be your host today. The region of Durham exists on lands the Michi-Sagig Anishinaabe inhabited for thousands of years prior to European colonization. These lands are the traditional treaty territories of the nations covered under the Williams Treaties, including the Mississaugas of Scugog Island First Nation, Alderville First Nation, Hiawatha First Nation, Curved Lake First Nation, and the Chippewa Nations of Georgina Island, Beausoleil, and Rama. We honor and recognize and respect Indigenous peoples as rights holders and stewards of the lands and waters on which we have the privilege to live. In our efforts towards reconciliation, we continue to build and strengthen the relationships with First Nations as we commit to learning from First Nations as well as the large Métis communities and the growing Inuit communities here in Durham. We commit to learning from Indigenous values and knowledge, building opportunities for collaboration, and recognizing that we are all connected. Please share in the chat the territory you are joining from. Today's webinar is AI Impacting Clinical Care, Advances in Management of Complex and Chronic Diseases. This session is part of the Webinar Wednesday Healthcare Innovation Round series and has been certified for Main Pro Plus credits. It is my pleasure to introduce Dr. Alexandra Greenhill. Dr. Greenhill is an ER and family medicine doctor, a leading physician in digital health innovation, and co-editors of the AI in Clinical Medicine book, Wiley 2023. She is the founder, CEO, and CMO of Careteam Technologies, a care platform enabling health teams to support patients along their healthcare journey. Alexandra is on the boards of Kai Cancer Research Society and the Vancouver Foundation for the Physician Innovators, and received many recognitions, including Top 40 Under 40, Startup Canada's Women Entrepreneur of the Year, WXN Top 100 Most Powerful Woman in Canada, and Queen Elizabeth II Diamond Jubilee Medal of Service. Please note that we will have time for Q&A at the end of today's presentations, so please type your questions in the chat box at any point. Thank you for being here today. I will now pass the screen over to Dr. Greenhill.
Thank you so much, Melissa. And we are joined by a special guest, somebody that I've collaborated for a long time with now. Sonia Kumarsigan is the CEO and founder of Body Brave, a national charity focused on people with eating disorders, and she's also at the Canadian Medical Association Patient Voice. She's a force for change, a social entrepreneur, someone who is not afraid of jumping deep into the fray of new tech initiatives. And I'm very honored to have her join us as a guest to talk a little bit more about the reality of what it's like to bring technology into the space of chronic and complex health issues. And so it will be my pleasure to figure out how to bring in an overview. Thank you so much to everyone who filled out the pre-survey, because it helps us make this into a series that's going to be successful. It's part of a series of webinars, and so the next one is in 2 weeks, but this one is focused specifically on complex and chronic diseases. But it's part of our effort to try and upskill everyone about all of this AI behind the chat and the drama that's happening right now with OpenAI and who's the leader. All of these technologies are coming your way. This is a CME accredited event, so I'm declaring and disclosing my conflict of interest. I have a number of engagements, including the companies in technology that I run, Careteam Technologies. I'm also on faculty at UBC. I serve on several boards, including Kai, the Cancer Research Society, Vancouver Foundation, Physician Innovator, Yogo Health, UBC Care Anywhere, and Creative Destruction Lab. And the one that I should probably add in there is I also chair the disbursement committee for the $10 million CMA and Scotiabank, the Canadian Medical Association Scotiabank grant for healthcare unburdened. So if you are thinking about an administrative a technology to reduce administration. There's time to apply and be considered for a project. So let me know afterwards if I can help. But the presentation that follows is influenced and informed by all of this, but it's meant to be an overview. And I'm mostly here because of these two documents. Melissa just mentioned the book that we just published. It's a collaboration across 120 doctors from around the world that I was a co-editor of, and our effort was to create a textbook. And so it's a textbook to elevate everyone's understanding, and a chapter on each specialty, but also a wraparound as to what is AI and where it's going. And the cover of that was actually done with AI design drawing, which at the time when we built this a year ago was not possible or easily accessible, and now it's everywhere, but we anticipated that. So that was one of the reasons I'm here. And the one document on the left is I helped with an initiative across Canada on how do we implement AI in healthcare. And so I can tell you that in an hour, we're going to do an overview. We're not going to do a crash course on everything, but we should have an interesting discussion. And the other disclaimer that I want to add is why. Why am I here and not sort of seeing patients and doing clinical care? Is the massive growing gap between what's possible and what actually happens has gotten worse in my 2 decades plus of practice, and that makes me frustrated. I thought I'd be Beverly Crusher on Star Trek. I thought I'd have one of those devices that actually tells you everything about the patient, genomic analysis and floating cells. And instead, this has been the reality of my practice, and I know many of you online will resonate. It's the busy waiting room, got me getting busier. And during COVID, maybe sparsely populated, but it's coming back to this fairly quickly. And this too is 40% of patients who don't have a GP. What do we do? And this is a joke, but it's also not a joke, because a lot of people go to Dr. Google and now to ChatGPT, who gives them all kinds of weird answers, and we need to figure out how to make it better. So this is the outline of what we're going to spend the next half an hour or so. I'm going to walk you through the pre-survey results, trends, what is AI, just so we have a common understanding. There's interactive components in this, and so you'll be able to comment in chat and answer, so that we can have an engagement and understand where everyone's coming from. We're going to talk about specific AI for complex and chronic diseases, and then cover examples, and we'll hear from Sonia about her experience deploying technology and the questions that she had, and then both of us will take Q&A. So the pre-survey results, how familiar are you? Some are very familiar, some are somewhat, and it's sort of some are just starting, and welcome to, and if we use any acronyms you don't understand, please put them into the chat. I'll try and keep that in mind. How familiar with your AI? This is I've given this talk many times, same survey, and it's very classic. Most people tend to be more familiar with technology, but we're still all new to AI. And so you see that golden bar in the middle. How familiar is your organization? Even less. And so humans are ahead because they started reading and they're being curious. And because you've shown up for this session, you're going to be the leaders, helping everyone else around you upskill on this. And they have to. And then how excited are we? Most people tend to be on the excited side, including patients. And there's a lot of fear mongering as to like, this could be the end of the world, but we've all lived through, the beginning of the internet, or even like books, the amount of people who are afraid that will corrupt society for forever, the printing press. And so let's make it and shape it into a way that serves us. And I just want to do a little plug for the role Canada has in that space. The 3 godfathers or grandfathers of AI are all in Canada. And so Richard Sutton is in Edmonton, Jeffrey Hinton in Toronto, Joshua Bengio in Montreal. And we have the highest concentration of everything: AI startups, AI graduates. And these are some of the names and organizations working in that: Creative Destruction Lab, Digital Supercluster, that I was on the board of until recently, like exciting initiatives. And so we tend to be complacent about how good we are in Canada. We are amazing at AI, but there's a risk of us actually missing out. And the other big risk in AI is diversity. This is statistics that Element AI pulled out, is only 12% of researchers are women, 15% know about it. And so, if you don't have diversity in designing AI, you're not going to get great products. And so how many people are in healthcare or physicians who are designing AI is even less. I tried to find those statistics, but in most places, I'm the only one who is a doctor, and I'd like to change that. So that's the purpose of our talk. And why it matters, let me give you two examples. They took pictures, black and white, from, I think, the New York Times, and they gave it to AI and said, please comment what you conclude. And one of the things it concluded is that white men matter and nobody else does, because all of the photos were taken with a white man in the picture, and therefore the AI concluded that people who are not white or women were secondary citizens. And so it amplified the bias that the data contained, even though it wasn't intentional bias. And these are historical photographs where men were more photographed. And same here, there's a sweet teen girl that everyone in AI knows, a Tay, that was created as a chatbot, and it was trained by online users to be extremely racist in 24 hours, and therefore had to be taken offline because it perpetuated all kinds of untruth. And we're seeing that a lot right now with the social media propaganda wars as well that are happening. And so my point here is that you being here is fantastic. We need to upskill on this. We need to start being more involved, or otherwise the changes that will happen through AI are not going to be good in spite of all of our excitement. And so just to level set the trends in AI is that this is coming, and you should never think of AI in isolation. The World Economic Forum published the Fourth Industrial Revolution concept, and it's like the first industrial mechanization and mass production, then automation, and now we have a convergence. And so it's AI meeting biology and genomics and all kinds of other fields. And so it's AI as a tool within many other tools. And so everyone right now is in the all hype or be scared and run type of a scenario, and sort of different people argue about that. But the reality is that this is all part of a predicted change. And the Gartner is a consulting and research organization from the US that has mapped this, and it applied it to pretty much any technology, whether it's electric cars or Google Glass or portable ultrasounds. You go from somebody invents it, everyone gets excited, then they realize it's not quite ready for mainstream use because it's too expensive or clunky or it doesn't work, and then everyone walks away, and you end up in this period of time where they have the impression that nothing has happened. And for AI, they call that the winter of AI. And then suddenly it's everywhere again. And so first interactive question of the session, please put in your chat, where do you think AI is right now on that cycle based on what you see or experience? So, there's 77 people. If you start putting in answers into the chat, we should be starting to see them come through. Some good guesses here. Peak. Slope. That's awesome. All right, we're going to collect all of these afterwards and reshare them because they're also sort of important, and anonymize them, of course. But part of the interactive nature of that is it helps you think about, like, where do I think it is? And so it depends on who you ask and what type of AI you're talking about. But for overall AI, we're somewhere here. We're the beginning of that slope of enlightenment, and we're going to see 10 years of incredible innovation occur. The peak of inflated expectations has actually happened on general AI, and for the last 10 years, all planes landing at the Heathrow Airport in the UK were directed through AI, because they have a plane landing every 90 seconds, and humans can't adjust some of these things. And so that has happened. Where is healthcare? Far behind, but not too far behind in some other ways. And so if you're looking for certain types of more advanced AI, you can argue that that's the peak of inflated expectations. Will we have completely sentient and intelligent robots running around in the next couple of years? Probably not. But they exist, they can do all kinds of things, and that wave is going to come into the future. But it's just helpful to think about where are we in the cycle and how soon can we expect things. And so things are maturing, and you're going to start seeing AI in everyday use in healthcare, because it's already in everyday use. Every time you do a Google search or use Airbnb or use any of the travel apps or tools. The healthcare always lags technology because part of it is we're so busy. I love that cartoon because it's so representative of the truth. We also very fearful about negative impacts. We have time to adjust. So all kind of good reasons, but the main reason is often this. And then this is a great way of actually thinking about that is who wants change? Everyone puts their hands up. Who wants to change? Suddenly no one does. And who wants to lead the change? And suddenly everyone's gone. And so we are so busy in health, especially post-COVID, that there is a challenge of thinking about how do you introduce new ideas into the workplace, but it's coming. The Singularity University has this framework and they call about the 6D. First you digitize and then it looks deceptive. It's a very small change, doesn't look like much, but that little small change snowballs literally in something that becomes disruptive, and then you demonetize so that the money transaction disappears. You democratize so everybody can have access to it, and you dematerialize. It's the hospital at home. Do you really need a hospital if people can be taken care of at home? Do you need really an office if the telehealth consultation is enough? And you can do a lot more with a telehealth consultation than just video. And so what is AI? Next question is in the chat again, when you hear or see the abbreviation, what do you think is it short for? I'm so glad so many of you said artificial intelligence, because that's what I would have put in as well. But it is a slightly trick question if you think about it. Is the American Medical Association has decided that in all of their documents, AI will stand for augmented, because they want to emphasize the importance of humans in the loop as part of the conversation, especially in healthcare. So if there's one thing that you remember, and only one thing that you remember from the entire presentation, is if anyone tells you we use AI, you have to stop them and ask what kind of AI, like what do they mean by that term, and be a lot more specific of, is it a subtype? And I'll walk you through some of the words that you can start recognizing around this conversation. But before that, I will do a plug for the other type of AI, appreciative inquiry, which I think we need to have a lot more of in healthcare, which is not problem-based. Let's look at what doesn't work and how to fix it. But it's the opposite, is how can we think of something that works well and how to do more of it. And I had a friend who actually showed up to an AI conference, and she called me and she said, I'm at an appreciative inquiry conference. And I said, please stay, because you're going to learn a lot. And it was true. She did change her life. So please ask, what is AI? The crash, sort of a quick course on AI, is the perception is that there's a black box or magic sort of in the middle. This is from a paper that I wrote with the Dean of Computer Science at Northwestern University, Dr. Edmonds. And so we worked on sort of like, how do you actually explain this sort of a connection or mystery that people feel between data's coming in and suddenly you have an insight. The easiest way to explain that is AI is closer to language and statistics. And so it's not good at math, but it's good at assessing probabilities based on patterns that it detects. And then the way to think about it is a spectrum between how much is a human involved in the interaction, how much is machine driven. And so data science is essentially statistics, and it's human derived. We put in rules around what and how to measure. Machine learning is getting closer to a machine. So it can start with a few designed rules by a human, but you can rapidly add the ability for the machine to keep learning on its own according to rules and patterns that it sees on its own. And then you have deep learning, which is the machine is really freed up from constraints that humans have put in to look for patterns that humans may not detect. And then you have augmented intelligence. So whatever the machine spits out is shown to a human, and they can then respond to it. And through that response, it improves the algorithms of probabilities. And then finally, you have that sort of a artificial general intelligence, which is true sentient, that everyone's working towards the idea that can the machine think completely for itself. And so these are important constructs to remember. Google has published these 7 rules that essentially mean don't be evil about creating AI, that the industry is adopting. There's a lot of conversation about what and how we should do. Should we do more guardrails, or should we let the technology figure out and explore things and be as creative as we can be, because then we can get the biggest benefit. And a lot of that division into the two camps is what you're seeing right now play out with a decision as to who leads OpenAI. And happy to chat about that if there's lots of questions in the Q&A. But it's the idea that, AI should be regulated, but then how do you regulate something that's almost like a video instead of a static picture? You can publish an article and have it peer reviewed, but with AI, you can't really publish anything and have it reviewed. And so that's the kind of questions that we are asking ourselves right now as we're trying to do the right thing using these new and exciting technologies. So that's a quick overview of AI in order for us to better understand, okay, well then how does it apply to complex and chronic diseases? And so if you think about a patient journey, people produce maps, and sometimes you're lucky and they get color coded and they seem organized, but essentially most patients go through a symptom to then a series of steps to arrive at potentially a diagnosis, and then a series of steps to deliver treatment. And if it's a short condition, we call it acute. If it lasts for more than 3 weeks or 6 weeks, we call it chronic. It can be a very complex or very straightforward. One disease versus, you've had a car accident and you've affected many symptoms. And so this is an actual cancer pathway map the BC Cancer produced based on research. And if it looks like snakes and ladders, and because in many ways to patients it feels like snakes and ladders, this is another one produced by CHIO and a number of other pediatric organizations that looks like at the patient journey from just through the diagnosis period. And I'll share the slides afterwards and you can read the text, but essentially most people are very lonely, confused, overwhelmed. And one of the things we're designing right now is AI for every little step from the perspective of whatever silo is looking at that. And so we call it a healthcare system, but it's not a system. You have a collection of organizations and people, hospitals, rehab facilities, then you have all of the medical providers and allied. You have insurance and pharma who are part of our system. And many people are like, well, they're not public, but they exist and they influence what happens, and they fund research in AI and they deploy AI tools. And then at the bottom, you have almost this like separate sector of home and community. And each one of them is deploying AI efforts. They're all deploying it in a certain direction. In many ways, it starts to feel like the elephant and the blind man. And it's an old tale from the Sanskrit where the blind man was sent to touch an elephant and describe it to the emperor, and everyone described whatever they touched. And so to one person, it was the snake because they're holding the trunk, and the other, it's a tree. And the argument around what we're seeing and what we're believing is because our perspective is on a particular part at a given moment in time of the journey. And one of the things we need to do is figure out how do we connect all of these and start creating AI across if the data actually resides into tiny little silos as well. I talked to you earlier about the gap. This is a slide that comes directly from the World Health Organization. This is their explanation to say lots of the research that's published is just not implemented. And so beyond the excitement that I have on AI, if I had a magic wand, I would just have a stop for a year and implement what we already know works. Full stop. And then we can add all kinds of fancy predictions on top of it, because there's so much evidence and research on things that help people. And this slide from the community involvement is the ecology of medical care. The tiny little thing at the bottom is who's hospitalized, and the big square is who needs help. And so we keep investing in acute care when we know that what makes people better is community care. And so we need to realign a lot of our thinking and desires. But hospitals have lots of data, so it's easier to run AI on that than it is to run it in the community, where most of the things are still interactions that are verbal or paper or fax, and therefore we can't deploy some of that technology there. And so I'll show you in a minute some research from the Canadian Medical Association on what makes Canadians sick. And these are some of the options on that slide. What do you think is the biggest? What is the biggest predictor of someone becoming sick? And please put that into the chat. I love the engagement. Yes, perfect. So, it depends on how you consider that, but this is the research that the Canadian Medical Association pulled based on a number of studies, and everyone who guessed lifestyle is right, because it's even bigger than a lot of people imagined in terms of its impact beyond biology. So same genetic makeup, your ability to survive and thrive in life depends on a number of external circumstances. And the interesting other one is your healthcare, is access to it, or the weight and sort of materially impacts your outcomes. And so I thought that slide was particularly interesting because we spend so much more on our research on the biology part, and on the environment was Kim Campbell, our former prime minister, gave an amazing talk on how global climate biggest impact is going to be healthcare, because availability of food, natural disasters and the cause that create, and then the pollution's impact on respiratory illnesses and allergies and a number of other factors. And so our environment not being okay in this slide is 10%, but I suspect in the future it's going to go up in terms of percentage. So when I saw this slide, the natural next question became what makes Canadian better? And so, I'm not good. You can put in some ideas as to what you have in terms of what's the biggest predictor of what makes people better. I've done a lot of research on that, and I'm validating what you're about to see. But what makes Canadian better is healthcare, obviously. But the number of other things are adherence to the advice that is provided, the personal mental resistance that patients have, in the sort of the resilience that they have faced with the circumstances. But then the bigger boxes are all of this support. It's proper nutrition. The person who buys and cooks the food, it determines whether this person with diabetes and heart failure is going to have good or bad outcomes, even if they're very compliant with their medication. It's lifestyle, it's environment, as we just mentioned, but it's also emotional support. Am I traveling this journey by myself? Informational support. Does anyone helping me advocate for myself and gather the information that I need? And then just logistics, is there someone to drive me to my appointments after my stroke or not, determines whether you can rehab successfully. And so that little diagram we just saw maps to a precision medicine article where it's now theoretically possible to actually wrap all 4 of these dimensions around the patient, in real time analyze environmental factors from databases around environmental pollution in the area. And so you can tie some of these big data sets of the environment to the social factors available to that community and that person, to then physical and chemical factors through testing, and then start predicting, this person is not getting better through the healthcare efforts within the larger context. And so right now, this is still difficult to do and expensive, but the cost of that is coming down. The speed at which computers can analyze is coming down as well. And so we need to start thinking larger than the box of I'm treating this person for this condition, and tying it into some of the other factors that are influencing their health, that go beyond medicine, beyond healthcare, beyond social factors, and even touch their environment. So from the same article, that's another neat little diagram of how to think about the components. And so bolting in different data set and asking computers to say, from everything that you see, what do you think the pattern is? And then having a human analyze the result and say, oh, I didn't realize the impact of this fire season on my patients with COPD. And if it produces a result that is surprising, we can sort of validate that and say, we've verified, and that hypothesis is not right, feed it back to the computer so that they can adjust the protocols. So this is a joke that made the internet, but it's just funny because in many ways, don't we all wish we had something that we can just point to a complex question and say, can you please tell me when I can park? Or this patient comes in with so many odd and bizarre presentations. When IBM Watson first came out, that was what I was hoping would happen, is I can actually put in a set of symptoms that some of my most complex patients have, and it will spit out a really good diagnosis. I've tried that with ChatGPT. It's better than IBM Watson, but still not there. And we're getting there. But if you remember that first slide I had about shortage of doctors and patients treating the iPhone as their primary care physician. The interesting thing with everything that's happening right now is you have this emergence of do-it-yourself healthcare. And there's a perception in the space that we just don't need doctors. We're going to have dispensing machines and minute clinics and Walmarts and other places, or a patient can self-diagnose and come out. And especially for people with chronic and complex diseases, so much of the success in treatment has to do with a therapeutic relationship. It's with the surfacing of things that they don't even know to complain about or talk about or willing to admit to themselves. And so I worry a lot about this trend to do-it-yourself healthcare, especially for people with complex and chronic disease, where well-intentioned people design technologies that are not actually very successful. And so one of the chapters that I wrote for the book was the AI-enabled consumer-facing healthcare technology, and you're going to see a lot more of it, largely because there's such a demand in terms of unmet needs, bottom right, is because there's such a shortage, people feel that they don't have any other option than turn to devices and apps, including ones that have AI in them. There's a lot of funding because there's a need, and a lot of the investors are like, my mom, my grandmother, my best friend had this condition, therefore why don't I fund this? It's easier and faster than ever to spin up a website and say I'm doing AI. And so there's a lot of people who start with good intentions, not knowing how difficult healthcare is. And oftentimes I have to tell them, well, did you do a literature review? Did you do a privacy sort of a setup? And they're like, what is that? And so you have this convergence of these four factors where people are more empowered in everyday life to do it themselves at banks and grocery stores. They can't have a GP. There's funding out there. There's lots of apps and technologies. And so the consumer technology in AI in complex and chronic disease is outpacing what we're given within our work environments. They have devices and tools that are ahead of everything that I use in my practice sometimes. And so I'm going to talk both about things that are available to clinicians, but also things that patients bring. And they fall into these five sort of categories. Is something that encourages their health and wellness, something that detects symptoms and helps diagnose, something that tracks the symptoms and monitors the treatment, something which is supportive or self-treatment of the disease, and then the researchy part at the bottom. So there's five categories of tools that exist right now. The interesting thing about this is, and really important thing is DEI, diversity, equity, and inclusion. If you actually look at who owns these devices in the consumer space, it tends to be the younger and higher income people. And not only that, but the people who are well. If you look at this graph, it actually says, what's your health status? And the healthier you are and the richer you are, the more likely you are to have a device. And so a lot of these technologies risk amplifying the societal issues we have, because obviously having a chronic disease puts you at a higher risk of being financially challenged, and therefore you're the one who needs the app and the device, but you can't afford it. And the scary other slide that I found, this is Rock Health, an accelerator in the States who did this together with Stanford, is people don't think about who they're sharing with what data, because they have something exciting, it kind of works, and they don't read the fine print. And so less than 25% of the healthcare apps in the App Store actually even have a privacy policy or terms of use. And most people just sort of click, 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 I've created an account, and how exciting it is. So this is the framing of what types and how it works. Let me give you some practical examples of things that work and things that don't work. I will share these examples with companies that have actually used the product, or I've met the founders and I know more about the stories, but I don't have any financial interest. And so before I mention individual names, just know that all of these are just things that I've experienced and I can talk about. Because either my patients or people are related to me, but I'm not promoting these companies. And so Natural Cycles was one of the first track your period apps, and sort of like, do we need birth control pills if you can actually do this using temperature and other devices, which was very popular with patients and backed by scientific research. Beats Medical was started by a physiotherapist in Ireland, and it's the idea that people with Parkinson's disease listen to this beat for 10 minutes in the morning and then can move around for the rest of the day in a very different way because it primes something in the brain having to do with movement. And so it's a incredibly interesting initiative that either augments treatment or sometimes replaces pharmaceutical treatment for patients, and it's all using AI. The Oura Ring is sort of this, and perhaps initially more of a fun thing to do, and we don't even know why these measurements matter, but with the amount of data that they've collected from so many people, they're starting to produce really interesting evidence around patient-oriented evidence that matters, poems. And so that this actual score of 90 points means something because it correlates meaningfully with people's feedback. And it's this massive install base of millions of people using this ring to track vital signs that is allowing them to continue to improve and eventually get to something that is interesting and meaningful and can help people with chronic fatigue syndrome and other conditions better avoid the push and crash that they always experience. Muse, the brain sensing headband, the ability for people to sleep better, meditate, reduce anxiety and stress through a device augmented with an app. This is a company that has produced TytoCare, that has produced essentially a stay-at-home first aid kit that is all based on technology that allows you to have all of the devices required. So if doctors doing telehealth, they can actually look in your ear and take your blood pressure and sort of support your family through this little kit that you have in your house. And a lot of the pediatric practices in the US have adopted that. Bina AI removes that kit. They can actually look at a video and look at and identify temperature and blood pressure and a number of other things through things that are captured by the video feed. And so these are virtual vital signs delivered by AI and surprisingly effective. I tried one when I was at the World Economic Forum meeting in China. There was a Carnegie Mellon had a voice-based one. And so essentially I say a sentence that they had sort of pre-read a 2-line sentence, and they could get my height, weight, blood pressure, ethnical origin, and I have really low blood pressure. So this was like, how did you know? Like, was there something in the mic that I held? And they explained that essentially they measure the thorax size on large samples of humans, and from that information they can infer data. And if it's wrong, then we feed that information back into the machine, and it gets sharper and sharper. This is another exciting sort of a tool around figuring out vital signs around movement in the patient. The Epilepsy Foundation, so not just companies, actually building all kinds of tools and techniques. And so this is the Epilepsy Foundation from the US, built a medication tracker and seizure monitoring app. WooBot, Stanford designed a sort of a cognitive behavioral therapy through chat, validated with a number of studies. And so to all of our patients where we don't have any access to anything in terms of paid counseling that they can afford, this becomes a really helpful tool of primary psychotherapy. But for everybody else who has a counselor but can't call them 24/7, this is a tool that allows you to get the kind of support and advice real time. And so the interesting thing about that last one is another company did an experiment where they told participants that a virtual human was controlled by a person. So you had a puppet or an avatar. The second version is a virtual human was controlled by a computer, so no human was behind the scenes. And this is the patient quote. They preferred the person who the virtual person that had no human behind it, because they didn't want to talk about it to somebody who was not a human, but also it was more consistent, faster, easier, nicer, and then the experience with a human behind the screen. So we make all of these assumptions that humans is often better, but the reality through testing is that a lot of these AI solutions that take the best possible human and digitize them to make them more available to everyone actually works. And so issues to look for And again, I'll share these slides, but it's really important to, when you're considering any of these AI tools in your practice or patients are showing up, are they really informed with what's happening and why this is it a nice gadget that gives them all kinds of scores that have no basis in reality? How true are those claims? Is there terms of use and privacy? Is the price transparent? So people get hooked for a month and then they suddenly discover that they have to pay $200 a month. Is it stable? So like, is this organization likely to be able to continue providing this service, or was that a well-intentioned effort that is gonna get stopped? A lot of the apps in the app store are now called zombie apps in healthcare because they're not maintained. And so they still exist. Somebody sort of has a night watchman maintaining the basics, but there's no continuous effort. A lot of them do research that's not regulated. A lot of them, you give away your data ownership, have usability issues. And so people try them, they don't like them, and then they conclude that technology is not good for me. And one of the biggest ones for me is that number 10, fragmentation. If you remember the elephant and the blind man, we have more and more apps that contain all kinds of tools, and the effect on diversity and inclusion. And so a couple of negative examples is all of the 90 plus apps around skin cancer have issues. And there's a lot of claims of how precise they are, but they overcall and they undercall. And so that is something to watch for when patients arrive with that. So many of these diet apps, when you actually go and see the studies that they claim on the websites, it's 8 people retrospective, and yet it's sort of, put in as like science approved treatment. There's a lot of the telehealth companies that sort of say like, oh, we have AI behind them. Babylon famously just closed because there was a lot of questions as to the veracity of the claims. There was an app in the States, Cerebral. 100% of patients who engaged were diagnosed with attention deficit disorder in less than 30 minutes, and 100% of them were given a prescription. And so there was an internal coup of people who said this is not okay, and all of that came to light. But they did operate for many years without anyone noticing this trend. And so I will hand this over to Sonia in a minute to give you another example. And for this one, I'll do a disclaimer. This is the technology that we built at Careteam. The essence of what we wanted to do is try and create something that works across and connects and starts putting together some of the AI pieces so that you have that continuity from screening to diagnosis to triage, however the patients arrive at the clinic, and sort of realizing that if you have an eating disorder, you can put your hand up and say, I have it, and contact Body Brave, but you can be referred by a GP or a specialist, and then the entire continuity of care needs to happen, and the data needs to go back to the organization, and it needs to go back to the patient. So it's a very different way of viewing things. And so Sonia, if I can ask you quickly to talk about your very exciting, just published BMG study.
Sure, thanks. Yeah, I'll keep this short. But we just before the pandemic hit, eating disorders are underserviced as is. So when the pandemic hit, there was this exponential surge for people seeking services, and there aren't many providers out there. So Body Brave is one of the only ones in Ontario. So we had thousands of patients wanting to get help, and we really only had a staff team of about 6 to 7 people. And of that, only 2 are actually doctors to do medical assessments. So we had to rapidly figure out a way to address this demand. So that's where Careteam came in, and it was pretty revolutionary for Body Brave and the services that we provided. So we rolled it out in 2021. And what we were finding with folks is that they were getting onto the wait list and they were sitting there for long periods of time. And then they were dropping off because they lacked the motivation, or they were finding that they were worried about it. They didn't want to talk about it. So we decided using Careteam to actually put in a few steps, and actually critical steps, before they reach that intake call with a clinician. So essentially, we worked with Careteam Technologies. We actually co-designed with them. And we have these interim steps where we build motivation. We also we talk to them about what's going on, and all of this can be self-directed. So they self-sign up for the platform, they can access resources immediately, they can self-educate, they can start monitoring their symptoms, they can complete check-ins, all of this stuff before they even get to the intake call. And it was really fascinating because, like Dr. Greenhill was talking about, we started to notice patterns that we had never noticed before because we were really forced to map the patient journey in a way that we'd never done before. It was also helping us to engage patients in a way we hadn't as well, and also getting feedback from them and data from them constantly. So we were taking that feedback and data and immediately iterating into the next cycle. So, okay, they're telling us that this isn't working so well, or this is working great. And then we would build that in, we'd have a conversation with Careteam and actually build that into the app. Which was very new to us, but I think it really served our patient population very well, and our providers. Actually, they were finding that patients were coming to them a lot more prepared, feeling more empowered. So it was quite revolutionary. It was also much easier to really talk to folks about the power of this type of technology. We were seeing great outcomes. So as you can see, again, we're a very small community-based healthcare organization, but we've been able to get funding for some of these ideas now because of the scale at which we've been able to provide care with such a small team. We've also been leveraging some of the other aspects of the app, things like predictions on how engaged people are. So having leading measures on how folks are going to do in a particular program is pretty rare. So it's really fascinating to see within Careteam how engaged people are, and there's a special metric that you can look at, and you can kind of predict whether people will drop off or they'll stay committed, or we can kind of look at the different populations and the different patterns within patient populations. So then we can actually customize our interventions for those groups of people. So I think I'll leave it there, but it's been a really interesting journey. We just published a couple of weeks ago. Back to you, Dr. Greenhill.
Thank you, Sonia. And I mean, so this is the interesting thing about technology. And there was a question in the chat of like, how do we figure out and pay for it? And it's a fraction of what we're used to. And so think about a lot of the technologies that you use in everyday life that are either free or, sort of like, instead of adding one more person to the team, for a fraction of their salary, you add technology that empowers a team that used to see 500 patients to now see 3,000 patients, and you have data on exactly how well the patients are doing. And so you can create all kinds of opportunities here. Designing the technology is really expensive, and that's where all of those logos came into play of the great funding that we have from across Canada, from the Digital Supercluster, and the assistance we have from organizations like Creative Destruction Lab and a lot of the AIM Institute and other AI-based organizations. SFU was part of the group. Simon Fraser University was part of the group that we collaborated with to design the protocol for Body Brave, and UBC was the ones who did the study, University of British Columbia. But is that sort of think about AI as a consortium of organizations having to work together in ways that they hadn't worked before, because technology alone can't build these kind of solutions, and we as clinicians can't necessarily jump and drop everything and start working on it. So I'll do more Q&A, but I just wanted to leave you with these 2 slides, and they'll be in it. There's a free AI course on Google that's really, really well done. Again, I have no shares in Google, unfortunately, but they've done a really good job of trying to get people upskilled. And so it's 5 15-minute classes that cover in more detail some examples of what is generative AI, which is a subset of machine learning. And then if you want to read more, here's some suggestions on really good books, including, of course, the Dr. Topol, who's written some really great ones for healthcare. The other ones are more general AI, but I wanted to leave you with some reading recommendations. Well, Melissa, shall we do questions?
We certainly can. We have, I noticed one, where did it go? What app you consider to be the best in terms of functionality and privacy safety?
So there are 200,000 apps in the App Store. And so I would say about a quarter of them are actually really good. And what sort of it's the, I listed a lot of factors in it, but to me, a really good app should be based on evidence. There should be clarity as to who and how owns the data and what happens to it. It should actually have some validity. We can't just assume that because we digitize something that happens in real life, it will automatically work well in a digital format. So some sort of independent additional research. And then finally, it should be user-friendly. And so those four big components matter. Whenever I recommend apps to my patients, it's with caution. All of our CMPA and other organizations encourage us to be caution oriented with this. I give them disclaimers that I am or I'm not associated with that organization, so that they have informed consent, and I give them choice. I think it's really important for people to have options when they consider, and oftentimes it's because whatever they're dealing with, like especially with mental health, I recommend patient associations and various websites, but the idea of a therapist in your pocket is something that most people, especially with anxiety, need, and panic attacks and other conditions. And what's interesting is when people come back, they would have tried 2 or 3, and I can't predict which ones they're going to like the most. But with practice, you end up learning which ones appeal and how people respond, and so I can guide patients better to that. But I think the question of liability is often top of mind. And so one of the things that I do is I recommend this with great caution to people in my practice, and only because I have had firsthand experience with some of these tools and devices, and I've actually downloaded, tried, went on the website, researched, which is not something that everybody can do. And so I am the one who gives that information to the rest of the people in my practice so that they can start upskilling as well without putting in all the effort. The same way as each one of us has specialty areas, and we rely on each other, corridors, consultation, or mini presentations to teach each other the skills.
Ahmed had 2 questions, so I'm going to read each of them and then you can answer, because I think that's all the time we will have before I have to wrap up. Many of these AI tools build on patient data. What are your thoughts on whether patients are owed a share of the profits generated due to their contribution? And then his next part to it was, many machine learning models are black boxes, making them difficult to assess for bias or other issues. Do you think making the models available for review should be the requirement for health regulatory approval?
So great questions. This is awesome to see the engagement. The ownership question is all about precedent. Like, we all give our data to Google and Airbnb and all the other tools, and they keep improving it, and no one's given us shares in exchange for that. So I doubt that will happen, but I would like to see more patients involved in advising, and if you were involved in a more depth, then yes, there should be a patient advisory board, and they should be recognized and compensated for that. But same with clinicians. A number of places where I'm asked to step in and provide advice to the health authority or to various places, and everyone else is paid to be there and not me. So, like, let alone profit sharing, I would like to even just be paid for my time to provide the advice. The second question was about explainable algorithms. And so there's more and more of a push to do that. And those are the 2 tensions, is that sometimes when you explain the algorithm, you reduce the accuracy or speed of developing them. And a lot of people are saying, don't do that, let the machines run, spit out an answer, then a human can then modulate and augment. And so that tension will continue. We are in talks right now on exactly how to figure out, how do you regulate this, and how do you regulate it so that the regulation in Canada maps to what's happening in the US and Europe and beyond, so that there isn't like multiple standards of regulation. So I don't know the answer to that one, but it's a very topical question. There was a question on dentistry. I'll just say yes. So tons of applications, very surprising. Teledentistry and AI in dentistry is alive and well.
That's wonderful. What I'm going to do is I'm going to take all these questions and I'm going to send them to you, Dr. Greenhill, so that you can answer them directly to everybody, so that we don't miss on anybody's questions. Unfortunately, we have run out of time. So I'm going to start to wrap up. I'm going to launch a poll. First off, I'd like to say thank you very much for this absolutely incredible webinar. You have done absolutely incredible. There was a lot that I have even learned, and I'm a novice by all means. So thank you very much for today's webinar.
And if I can thank Sonia for you to come in and share your story. I think we need to make a lot of these less theoretical and make it real, because that's where we get progress. And having these kind of conversations and figuring out what does it mean at the end of the day to a team that was responsible for population of patients with eating disorders that they simply couldn't service. You know, the demand grew so much that, you know, when your wait list triples, and I see people getting appointments for obesity or eating disorder in 2027, and that's not good patient care. We can't get there unless we get AI on board. So thank you, Sonia, for sharing your story.
Absolutely. Thank you very much, Sonia. You're going to see on your screen a poll, and I'm going to launch that right now. If everybody could give us a satisfaction rating, it would be lovely for us to have that. Thank you very much.
And while we wait, I want to thank everyone who participated in the chat, and again, everyone who answered the pre-survey. This is a series, and we're trying to make it better. And so the series is going to happen in the spring, is going to be reflective a lot of your input. So watch out for the next wave that we're putting together.
Thank you very much for letting everybody know that. We have launched our community platform. I encourage all members to log in and join or start a discussion. All webinar Wednesdays, including this one, are now located in the community platform. And we have upcoming events. Please take note. February 6th, we will have our Calgary Winter Conference. February 8th, our Ahead of the Curve, and March 5th is our Up on Digital. So registration will be opened shortly on those. I thank you very much for everything, and Dr. Greenhill and Sonia, I appreciate everything that you've done, and I will share all of the questions that are left over. Have a great day, everyone.
Have a great day.
Bye-bye.